taking care of hundreds of critically ill patients. Basically every ICU turned into a COVID ICU. So, at first these patients were presenting with very significant bilateral pneumonia and severe hypoxemia that, Dr. Poor will talk more about, but seemed to be kind of out of proportion to their imaging findings. And unlike with the classic acute respiratory distress syndrome, these patients had what seemed like normal compliance, which he'll discuss more, but it was a little bit of an unusual pathophysiology. And unfortunately, these patients ended up very heavily sedated and even paralyzed to maintain kind of basic oxygenation to prevent kind of multi-organ failure. During that time, myself and a lot of other of the intensivists were on the rapid response team, and we were noticing that there were some patients who were on the floor who seemed fine when they were lying in bed, and it was once they sat up or stood up that they actually became severely hypoxemic. And when I say hypoxemic, I mean, normal saturations are anywhere from 95% to 100%, and these patients were in the 70s and 80s. So really severe hypoxemia. And this wasn't really anything that I personally had seen before, though I'm not a pulmonologist. The other interesting thing that kind of came to light while we were taking care of these patients was the role of some sort of a coagulopathy. There was increasing observation of thrombotic events. Our patients initially were dying of massive PEs. We had several patients in the neuro ICU that turned COVID ICU who had presented with STEMI and ischemic stroke. And there certainly seemed to be a very large amount of inflammation and a prothrombotic state. And actually, Dr. Poor was the first author on one of a couple of different studies that did show that hypoxemia was partly responsive to thrombolysis. But despite kind of starting everyone on anticoagulation, we still found that there were very significant rates of hypoxemia that seemed to be unresponsive to many of our therapies. At the same time, as a neurologist, parts of my division of neurology and neurosurgery started finding that we had very high case burden of patients with COVID-19 who were presenting with large vessel occlusion, including many who were under the age of 50. And this seemed very unusual to us as well. And this was a letter written by some of my colleagues, submitted to the New England Journal, just kind of explaining our experience. And so as a neurologist and a neurointensivist, now turned into a COVID intensivist, I was receiving patients who were already intubated, heavily sedated, and paralyzed. And in my head, I'm thinking about the high rates of thrombosis and the risk for stroke, and very frustrated that I was unable to do neurochecks, especially in patients who were prone for 18 hours of the day. These were patients where we couldn't even be reliably doing pupillary checks on them. And so as a neurointensivist, I think in particular, I was in a good position to start thinking about how to monitor these patients, because that's something that we kind of struggle with on a daily basis. So around that time, while we're thinking about how to monitor patients who are heavily sedated and paralyzed, we're wondering why patients are having strokes. And then, the other major clinical problem, which I was certainly not in a position to necessarily contribute to, was why are patients so hypoxemic? And this is before they develop poor compliance, that they may develop weeks into their disease process. So at that time, I was also working on some other projects using transcranial Doppler. And, when me and my colleague, John Liang, were speaking with some representatives from Nova Signal, we were thinking about the utility of TCDs in the COVID population. The idea being that, one, there were clearly young patients developing strokes, and we could not really understand the mechanism of stroke in this disease process. We wanted to understand whether it was feasible to monitor patients on anticoagulation. At that point, we're starting patients on anticoagulation. These patients are too sick to even get head imaging. And, oftentimes it was impossible to know whether there was an exam change. And so, we had talked about using EEG, which did not seem like a very plausible plan, just given the potential risk to EEG techs. And so we thought about using transcranial Dopplers to monitor patients. And then, the last kind of thought that I had was we don't really know what's going on with their cerebral autoregulation in these patients. And we don't know that for any patient. I mean, there are plenty of patients with ARDS who probably also don't have adequate perfusion of their brain when they're very sick. But this was a point where in my ICU, we had at most 28 patients, 2 patients to a room. And it was just, everyone was comatose, prone, paralyzed. And so this was a question that seemed very prudent while we were kind of surrounded by these pandemic numbers. And so what we had thought about was just going in there and doing manual TCDs if we ever had a chance to breathe from running from room to room. But as all of you know, manual TCD capture can be difficult depending on the skill set of the person who's performing the transcranial Dopplers. And as you can also see, it's obviously very close to a person's face. And there was a lot of concern over trying to keep providers safe during a time where it was unclear whether we had enough PPE or not. And so, during this time, there was also a huge shift within the hospital system itself, placing pumps outside of the room to try to minimize the risk to nurses having to go in and out of the room a lot. And so there were, just feet and feet of tubing that was used in order to try to minimize needing to go into the room to expose providers. On the bottom left, you can see that within the neurosurgical department, we started doing telemedicine in order to help examine patients where we felt like we may not be able to physically come in and see them because we were all kind of on COVID shifts now. And then on the bottom right, you can see kind of an early iteration of PPE that we were using when going into COVID rooms. But overall, there was this very strong feeling that, especially at the beginning, when we didn't really understand the transmissibility, we really wanted to be sure that we could keep ourselves and each other safe from getting infected. And so this was where the idea of using NovaSignal's robotic system kind of came into play, because the idea was that the robotic system would optimize the probe placement and find the window and then maintain the signal. And so we could set the robot up, leave the room, and then when we wanted to evaluate or perform a procedure, we could just go back in. And so that was the thought process behind using this robotic system. So, when we were first thinking about it, my thought was these are patients who are hypercoagulable. They're clotting off their lines. They're like everything that we put in them, they're clotting off. We were unable to even perform dialysis in some of these patients because they kept clotting off their lines. And so my hypothesis was that we were sure to find spontaneous emboli in these patients, and that must be kind of the reason that these patients were presenting with strokes and other, DVTs. And so initially we started by just taking a look at some patients some patients were on anticoagulation, some had to be off because of refractory GI bleeding. And so I was sure that I was just going to put the TCDs on and just see kind of high intensity transient signals everywhere. And of 10 patients we scanned for a full 30 minutes, we saw no spontaneous emboli in any of those patients. And that was kind of surprising to me. And in fact, I was quite disappointed at the beginning because I was so sure that that's what we were going to find and that we could titrate anticoagulation to, the number of hits that we found. And I was so sure just clinically that these patients must be continuously embolizing. And it seemed, at least with these first 10 patients, to not have been the case. So, the other thing that we noticed when we put the transcranial Doppler machine on is that the waveforms just really didn't look normal. And unfortunately, I was working in an ICU where by the time they came to me, we did not have a neurological status anymore. So, and unfortunately, very few of these patients actually survived. And so I don't know if there was undiagnosed intracranial processes going on. But certainly it's possible that some of these patients had hypoxic ischemic injury to their brain. Many of them were very hypercarbic. And and then, whether there was inappropriate autoregulation, whether there was a vasculopathy. I really don't have a lot of information, but we did note that there were very highly resistive waveforms in a lot of the patients, and that actually, surprisingly, in some patients, there were significant asymmetries, even though there was no history of any carotid disease, and a lot of these patients were actually quite young, where we wouldn't expect them to have had that. And so, that was kind of the other thing that came out of this that was very preliminary, was that these patients just don't have normal waveforms. Of course, these were all patients who were critically ill in induced comas. And so it's a little hard to kind of focus on this as a true finding. But while we were scanning patients and we're not finding any emboli, and certainly some of our patients had strokes, so we wondered, well, let's just do bubble studies. And so, originally even in patients who had strokes, we were being very judicious about sending an echo tech in to do an echo study, because the feeling was, if, no one was acutely going to be getting a PFO closure, it wouldn't have changed management. And we were basically just doing bedside ultrasound at that point by the intensivist. And so, simultaneously in some patients, we did both transcranial Doppler with bubble, and we would also look on echo, bedside echo for PFO and right to left shunting. And so I guess with that, I'll kind of move on to Dr. Poor, who can kind of start talking about what I found and how I called him and how he put it all together.
Great, thank you, Alex. And so, yeah, in terms of this backstory of the spring, which, quite honestly, we still have significant PTSD from, there were enormous number of patients critically ill in our ICUs and newly on mechanical ventilation. And they were initially billed as having the acute respiratory distress syndrome. And the acute respiratory distress syndrome is an inflammatory condition of the lungs where the lungs become injured. And as a result, the capillaries leak fluid into the alveoli, into the lung sacs. And as a result, gas exchange is impaired. So you get less oxygen into the blood, less carbon dioxide out. And at the same time, the lungs become very stiff. And the manifestation of that stiffness is when a patient is on a ventilator, you can actually see how much pressure is required to inflate the lungs, and you can measure compliance. But also the strange thing we were seeing is, when a patient is in, classic acute respiratory distress syndrome, they are seen to be in distress. They are working hard to breathe. And the reason they are working hard to breathe is because their lungs are filled with fluid. It takes a lot of effort to inflate them, and therefore they're in distress. But the pattern that we were seeing in many of these patients was that they had severe hypoxemia, so very low oxygen levels, yet they were comfortable. This is the kind of happy hypoxia that we were seeing, and they weren't necessarily in distress. And ultimately, when they were on the ventilators, they didn't really have significantly high pressures. And so this is a significant disconnect between the gas exchange and the mechanics, which isn't what we see classically in ARDS. And when I saw this initially in the spring, the compartment of the lung that comes up immediately are the blood vessels of the lungs, that this is a pulmonary vascular disease. And the big pulmonary vascular disease that we think about is pulmonary emboli. So patients with pulmonary emboli will have significant gas exchange abnormalities, yet they will not have changes in compliance. And because all of their D-dimers were elevated, because everything was clotting off in these patients, their dialysis catheters, they were having high rates of clots in very strange areas, strokes, venous emboli in various organ beds. It seemed to be that perhaps they were having, either macroemboli or microthrombi in their lungs. And as a result, I started giving thrombolysis to patients basically at the end of life who had, and they demonstrated immediate physiologic response, basically proving that, pulmonary thrombi were playing a role in their disease. But the part of this that was always a little unsettling to me was that if these patients had significant pulmonary microthrombi in their lungs, the blood vessels would then be filled with clot, the resistance in the blood vessels of the lungs would then be elevated, and therefore the pressure in the blood vessels of the lungs should be elevated, and the right side of the heart should fail. And this is what we normally see in pulmonary emboli. However, this is not what we were seeing in COVID. And we were kind of hypothesizing that if these blood clots were present, that there had to be some other vasodilatory process at the same time that allowed the resistance in the overall circulation to be lower. There was no way at that point for me to kind of prove that, and it was sort of in the back of my mind. Fast forward a few weeks, and I still vividly remember this. Alex calls me, it was a Monday afternoon, and she told me exactly the story that she just said, where she did the transcranial Dopplers on, I think it was 11 patients, and that she did these bubble studies, and that 9 out of the 11 patients had a positive bubble study. And I had a cup of coffee in my hand, and I almost dropped it, because this was exactly kind of the answer that I was looking for with respect to why this disconnect was happening. And so ultimately, we decided to, the next day, because I was the ICU attending in a different ICU, do these studies on the patients in the medical ICU. And we had 18 patients done. And of these 18 patients, we found that 15 of them had a positive bubble study. And as you know, PFO exists in about 20-ish% of the population. We didn't hypothesize that COVID-19 was causing intracardiac shunt all of a sudden, but that this was likely an intrapulmonary process causing pulmonary vasodilatation. And this is something that we published in the American Journal of Respiratory and Critical Care Medicine, and I'll talk about some of those results now. So again, with the bubble studies that were done, we did 18 patients, and 15 of them had a positive bubble study, so that's 83%. Again, we didn't have a way to determine whether these were intracardiac or intrapulmonary, partly because we weren't doing echocardiograms given the risk to the echo techs. And also the ones that we did do didn't really have very good windows. And so a transthoracic echocardiogram, it's very operator dependent in terms of whether you can detect those bubbles or not. So a transcranial Doppler is much more sensitive. And doing a transesophageal echocardiogram, while very sensitive, is invasive. So putting that probe all the way down into these patients who are, critically ill or with bleeding diatheses was not an ideal situation. And doing, the transcranial Doppler or these echocardiograms, required other people. And so a transcranial Doppler that was with this machine, such that we could set it up and essentially walk away and not be in the face of the patient, was ideal. Importantly, as Alex was telling me about this, she also told me that we could count the number of bubbles that go across. And so in the back of my mind, I was wondering, well, if we can demonstrate that these patients have bubbles that are crossing perhaps the pulmonary circulation, if we can quantify that and say the more bubbles they have, the more shunting they have, perhaps we can correlate that to how sick they are, and specifically the degree to which their gas exchange is abnormal. And that's something that we did. And so this is on the left MCA, you could see 3 microbubbles. And this patient had a P-to-F ratio of 166. I'll talk about what P-to-F ratio means, but it's a marker of gas exchange. So the lower the number, the more impaired their gas exchange is. Here on the right is the right MCA. You can see just chock full of bubbles, more than 300 bubbles. And this patient was very, very sick. P-to-F ratio was 55, sedated and paralyzed and so on. So the PaO2 is the partial pressure of oxygen in the blood, and the FiO2 is the fraction of oxygen that we're delivering. And the way we characterize the severity of ARDS, at least one metric, is known as the P-to-F ratio. That ratio, the lower it is, the worse it is. Basically means for a given FiO2, for a given amount of oxygen that you're delivering, your PaO2, a lower PaO2 means your gas exchange is worse. Or on the flip side, you would say for a given PaO2, for a given amount of oxygen in your blood, if you require a high FiO2, your gas exchange is worse. So many of the studies in ARDS characterize patients by their severity based on their P-to-F ratio. And our question was, if you have more bubbles, do you have a lower P-to-F ratio? And our study did demonstrate that actually pretty dramatically. With only 18 patients, we were able to show a pretty clear correlation such that the more microbubbles that we're seeing, you can see here, the lower the P to F ratio. The less microbubbles, the less. And so the question that arises is, well, okay, that's great. Does that happen also in classical ARDS? And actually a very big study was done in classical ARDS using transesophageal echocardiogram, which is equally as sensitive as TCD, but as I mentioned, obviously much more invasive. They found in I think 265 patients, only 26% of those patients actually had positive transpulmonary bubble transit, so going through the lungs. And there was no correlation with oxygenation, so no correlation with P to F, indicating that this mechanism is not a cause of hypoxemia in classical ARDS, but that this mechanism is a cause of hypoxemia in COVID-19 respiratory failure. And so there clearly is this element of the vasculature with this vasodilation playing a role. And so here are some echocardiograms showing intracardiac versus intrapulmonary bubble transit. You can see that the bubbles show up immediately here in the right atrium and then cross over within a couple cycles to the left atrium. This is consistent with a intracardiac shunt. With an intrapulmonary shunt, it'll show up in the right side of the heart, and then it will take a few beats for it to go through the lungs and then come back, and you can see it on the left side of the heart. Normally, when we inject these microbubbles, the bubbles go through the veins, they enter the right side of the heart, they go into the pulmonary vasculature, and because the diameter of the bubbles are bigger than the largest capillaries in the lungs, they should get stuck there, and we should never ever see them again. If, on the other hand, we see them on the left side of the heart, or they cross from the left side of the heart and continue on to the brain, then we know that either there's a hole in the heart, whether it's a PFO or an ASD or VSD, or that there's an abnormal connection in the lungs. And so what we found here, again, this high percentage in patients with COVID-19 respiratory failure implied that these patients didn't really have PFOs, that it probably was intrapulmonary shunting. And this disorder is very similar, it's analogous to a condition known as hepatopulmonary syndrome. And hepatopulmonary syndrome is a condition that occurs in patients with chronic liver disease. And as a result, unclear mechanism, but the capillaries become abnormally dilated. And when they become abnormally dilated, more blood flows through those dilated capillaries. And those dilated capillaries now allow those bubbles to cross through. And so you would ultimately see bubbles going through, and you'd have a positive bubble study. With an echocardiogram, it would be after more beats than with the intracardiac shunt. But with a transcranial Doppler, you wouldn't be able necessarily to tell the difference. The way this vasodilation causes hypoxemia is that the lung is a very smart organ. It tries to match the amount of perfusion that goes to areas of ventilation. So you have ventilation where gas is coming in and out, and you have perfusion where blood is going by, and they exchange gas at that interface. And the whole idea is to match the amount of perfusion and ventilation for proper gas exchange to happen. If an area of the lung reduces ventilation because of, say, scarring or pulmonary edema or bronchospasm, the lung, that area will become hypoxic, and the lung will respond by vasoconstricting that area. And therefore we get ventilation and perfusion matching. That's what the ideal lung does. If, on the other hand, the perfusion to an area of the lung is abnormally large, too much blood going by, then that blood that goes by cannot properly get oxygenated, and therefore the blood that passes afterwards will become low in oxygen and lead to hypoxemia. And with hepatopulmonary syndrome, it's been shown that the more bubbles that you have, the more hypoxemic you are. And so this disease is basically analogous to this. And this brought us to, again, that initial thought in the back of my mind where, again, we have patients who are, presumably having clot, microthrombi. Again, I didn't mention that, autopsies have shown these microthrombi, yet they weren't showing signs of increased pulmonary vascular resistance, increased pressures, RV failure. And this was the secondary component, this vasodilation that led to the balancing out or the masking of this clot, at least from a hemodynamic standpoint. And so, in conclusion, this is, abnormal right to left transit of the bubbles in the lungs in severe COVID pneumonia. And the percentage of these patients with this transit is much higher than those, the percentage of patients in the general population with PFOs in ARDS. And the degree of bubbles that we saw correlated with the degree of hypoxemia. And this, again, implies that the vasodilation that's occurring is actually a mechanistic in the pathway of hypoxemia and respiratory failure. And it is analogous to what we see in hepatopulmonary syndrome. And so we are, doing a much larger study now. And specifically, the patients that we did were all on mechanical ventilation and had been so actually for, quite a bit of time. And our question was, is this a phenomenon that's happening earlier in the disease process? Our patients who are on just a little bit of oxygen or on high flow nasal cannula, do they have bubbles? And do these bubbles track with their condition? So if they improve or if they worsen, do the bubbles kind of track with that? Could we use this transpulmonary transit as a surrogate marker, or even perhaps as a surrogate endpoint in clinical trials? Perhaps we may want to give therapeutics early on in the disease, and we want to see, do they affect the pulmonary vasculature in the way that we hope? And does the bubble count, for example, go down? And one of the interesting aspects of hepatopulmonary syndrome, and Alex also kind of alluded to this in some of the patients that she saw with COVID-19 respiratory failure, is this sign known as orthodeoxia and platypnea. So patients with hepatopulmonary syndrome have these abnormally dilated blood vessels of their lungs, yet when they sit up, they're more short of breath and their oxygen is lower than when they lie down. When they lie down, they're less short of breath and their oxygen is actually higher. So their symptom of shortness of breath worse when they're sitting up and lying down is called platypnea. Their deoxygenation when they sit up relative to lying down is known as orthodeoxia. And the reason that happens in hepatopulmonary syndrome is that these abnormally vasodilated regions occur predominantly in the bases of the lungs, such that when you sit up, more blood flows there, and as a result, hypoxemia ensues. And so we're doing these studies now, again, with the Lucid robot, with patients lying down, supine, and then sitting up at 45 degrees to see, do they have orthodeoxia, and do they have bubbles, more bubbles when they sit up? And this perhaps will give a little hints as to the underlying mechanism of why these vessels are abnormally dilated. So the other aspect finally is the therapeutic targets. Right now, treatment has been mainly anti-inflammatories and toning down kind of inflammation in the lung, either broadly with steroids. We have remdesivir, which is an antiviral, but a lot of the clinical trials now are really targeting pathways in inflammation. And so part of the question now is, should we be targeting pathways in the vasculature, specifically those that cause abnormal pulmonary vasodilation? Should we be giving pulmonary vasoconstrictors? And again, these are very interesting trials that should hopefully be going on in the future after we more fully demonstrate that this is exactly what's going on. Is that the last slide, Alex, I think?
Yeah, that's it.
Thank you very much for that wonderful presentation. I'm going to start going through questions. And the first is, was there asymmetry of the TCD waveforms? Was it associated with normal, low, or high velocities?
So that is a good question. It actually varied. Let me bring up, I just have some examples here. So most were actually normal velocities. There were a few that were high on one side and normal on the other side. And as you can see, this is over just kind of, 20 or 30 minutes. There also seemed to be quite a bit of variability in some patients and not in others. Honestly, this was, I would say, not the ideal way to actually study this question of whether there is some abnormality within the brain. I think I was literally just looking, in between crises of coding patients. I was just throwing it on patients who we hadn't woken up in 2 weeks just to see, like, do they still have blood flow? It was very rudimentary, I would say. So I think there's a lot more that could be done. I think if we could grab just, all these patients had arterial lines too. I think in an ideal situation, when this happens again in New York, I think the way to do it is to throw on the robot, collect arterial line data as well, and just see if there's any correlation with blood pressure, continuous CO2 monitoring, which we had on all these patients, and really try to understand this better. Unfortunately, basically none of these patients survived, and there were no autopsies. So I can't even tell you, it's really just a black box of what was going on in their brains.
Next question, did you rule out right to left shunts? High embolus burden is expected to lead to pulmonary constriction, and why do you think you didn't see that?
So yeah, one of the limitations, obviously, of our study was that we did not do echocardiograms on all the patients. Some of them had echocardiograms. However, none of them actually had formal bubble studies with their echocardiogram. I can tell you the one patient that we showed with the 300 bubbles, our jaws were on the ground when we saw that, partly because, I didn't really mention this as well, but we also hypothesized that those who had stiffer lungs, less compliance, would have less bubbles because they would be more like the classic ARDS, stiff lungs, inflammatory syndrome, and therefore not this vascular phenotype. And this patient had the stiffest lungs, had been in the ICU for a very long time, and had shockingly tons of bubbles. When we did the echocardiogram ourselves and did the bubble study, we didn't see any dramatic bubbles at all. But again, that it's hard to rule out the intracardiac shunt with just an echocardiogram. With respect to the pulmonary vasoconstriction, at this point, I don't think most patients have blood clots in their lungs. I think that's only a subset. I think there are, a cohort of patients with significant clot burden. And in fact, I am, running a clinical trial with the use of tenecteplase in patients with new onset COVID respiratory failure, but with a higher D-dimer greater than 6 times upper limit of normal. I can tell you right now in our hospital, we have a number of patients with COVID pneumonia, close to like 30, only one of them had a D-dimer greater than 6 times upper limit of normal, whereas back in the spring, there were a ton of them. So I think the clotting phenomenon is in a subset. I don't think it's the primary process.
There's a question about serial measurements in the same patient, and is there any change in the bubble study with improvement?
It's an excellent question, and that's a study we're actually doing as we speak. Our protocol now is to identify patients when they come into the hospital, to do the bubble study lying down, sitting up, and then to repeat that study at 7 days, or if there's a clinical change, either worsening or improvement. So we've done a number so far. We haven't really reviewed the data, but it's this, in my mind, is the most important question, specifically whether we can use this as a biomarker. Because if we can use this as a biomarker, if patients do in fact get better and their bubbles go away, then perhaps we can, therapeutically get them better and have their bubbles go away. And another question I have is, we have these quote unquote long haulers. I occasionally see patients in the outpatient world with, post-COVID respiratory failure. And they're astonishingly dyspneic, and they have exertional hypoxemia. And in the back of my mind, I'm wondering, do they actually have abnormally dilated, pulmonary vessels that are playing a role in this? And are the infiltrates and the fibrosis just kind of a red herring in the lungs? We wouldn't, our study now isn't necessarily looking at those patients. It's mainly the inpatients, but that is something in the future that I think should be investigated. The other aspect is, there's a question that's come up about in the autopsy series of patients in the New England Journal. They looked at patients with COVID respiratory failure and compared them to specimens from H1N1, and they found 9 times the amount of clot, but they also found this phenomenon known as intussusceptive angiogenesis, where the capillaries are becoming abnormally dilated and kind of sprouting. And we wonder whether this process is, first of all, irreversible, and whether we start out with pulmonary vasodilation that leads to that. And again, therapeutically, if we were to intervene, we would want to do so earlier. So identifying these patients early with bubble studies would be ideal.
Okay, there's a question, have you done this in non-ventilated patients?
Yes, we're doing that as we speak. So we're doing it in patients, again, who are coming in with, our criteria is that they should be mildly hypoxemic at least. So an oxygen saturation less than 95% on room air, or ideally, even more hypoxemic requiring oxygen. And so, I can tell you that the bubbles exist in those patients. But we do need to kind of tease out, more. We just started this. It's been a little while that we've had the protocol ready, but our numbers in New York were astonishingly low. Unfortunately, now we have many more cases, which has allowed us to proceed with the study. But yeah, the numbers are rising, and we are very aggressively studying these patients to better characterize exactly this phenomenon. And I do think that this is one of the major links in why these patients are behaving so differently from ARDS, the classic ARDS. In the pulmonary critical care world, there's been the kind of this pendulum swinging back and forth that this is not ARDS, we should stop calling this ARDS, it's a whole different syndrome, to this is actually just run-of-the-mill ARDS, we should just be treating it the same. And at the end of the day, I think it's ARDS with a twist. And we need to focus on how we can modify and modulate that twist.
Yeah, I think this second study that we're doing, the study that we're describing was really a study of convenience, and whenever it was convenient for me to throw on the robot, we did it. But these were patients who, on average, had already had the disease for over a week. Super sick patients, had already been on the ventilator for quite a while, and some of them may have been at what we would consider now to be the end stage. Before they died. I think the really important thing is to catch these patients early and understand how these bubbles change over time.
Okay, this is a kind of a two-part question, but number one, how do you think PFO cardiac shunt morphology could influence the pulmonary microthrombi shunting physiology? And number two, can you think of any other conditions like right heart strain or right heart failure other than hepatopulmonary syndrome where this phenomena is seen that you're describing?
So, it's funny, when I first saw the shunting, the first thing that went through my head was not anything like hepatopulmonary syndrome. I was sure that this was all due to high clot burden, elevated right heart pressures, and therefore like opening up intracardiac shunts that are usually quiescent or that we don't usually catch. Or it was some sort of like neoangiogenesis, but vasodilation had never even crossed my mind until I talked to Hooman. I think the question of whether there's a utility in studying TCD with bubble in patients with elevated right-sided pressures, I think that's a really interesting one. Certainly, Hooman and I have talked about studying patients with hepatopulmonary syndrome as a way of monitoring them. I mean, we're a big liver center as well. And so I think Hooman actually sees probably almost all of the patients with hepatopulmonary syndrome, since he is a pulmonary vascular specialist, but he can probably answer this question better than I can.
Yeah, I mean, I think this was like one of the most fascinating things when Alex called me, and I didn't even fully appreciate that this technology even existed. I mean, I knew that TCDs existed and I understood their concepts, but I didn't know that you could truly do, you know, this quantification of a bubble study and be so, you know, sensitive that we could see one bubble and that one bubble is an abnormality. You know, with respect to whether these patients have PFOs as well, again, part of, you know, the way that you would obviously do that would be with an echocardiogram, you know, ideally a transesophageal. And, you know, I think given that these percentages are so high, you know, in our current study, we're just kind of excluding those who have a known PFO or who've had a history of stroke and therefore, you know, may have a higher risk of having a PFO. In terms of the use of this technology, I think it has, you know, tons of room in the pulmonary vascular disease arena. You know, my main kind of clinical interest is actually pulmonary hypertension. I, you know, run a pulmonary hypertension center. And one of the big questions in my mind is that we use these pulmonary vasodilators. So pulmonary arterial hypertension is a condition where the blood vessels of the lungs are abnormally vasoconstricted. And we give these medicines that remodel them and they get better, yet we're not entirely sure how they actually work. And some people hypothesize that it's just vasodilating other areas of the lung. And I desperately want to know, for example, you know, do these patients who dramatically respond to, you know, pulmonary vasodilators, are they having this bubble phenomenon? Is this the late phenomenon, the shunting, you know, in severe RV failure that happens because of the high pressures? And then also, you know, we have patients with hepatopulmonary syndrome who end up getting liver transplants, and having hepatopulmonary syndrome, at least severe hepatopulmonary syndrome, adds list to your MELD score and augments you, it puts you, you know, pretty high up on the list. You know, with this machine, can we put it on and see how quickly the bubbles resolve and give us insight into, you know, the speed with which hepatopulmonary syndrome resolves. I think one interesting aspect, at least with COVID, is that, you know, right now we're assuming that the vasodilation is occurring because of inflammation in a specific area. Could it be that, you know, COVID is causing some weird evil humor to percolate through the system and cause a hepatopulmonary syndrome-like situation? In the same way that the liver is not clearing some substance, maybe you know, COVID is causing some kind of thing where that's occurring rather, you know, than this direct injury insult that's causing vasodilation. It's unclear.
Okay. Next is a question about was the Lindegaard ratio calculated to check if the resistive waveforms were systemic versus intracranial?
No, I was sleep deprived and overworked during COVID and wasn't smart enough to do that. But certainly I will say, if we see abnormal waveforms, I mean, you know, one of my biggest question is like, these patients who have this weird brain fog, do they have normal waveforms? Is this, you know, is there some impaired autoregulation, or is it just that they're hypercarbic but awake? And, you know, what's going on? In an ideal world, I would do this same study with, you know, just looking at the waveforms as well. And I would have done it in a very different way, and checked Lindegaard, you know, I would have done the whole thing the right way, the way that ASN members are asking. But no, at the time I was not even, that was not even crossing my mind as a sleep deprived, terrified intensivist.
Okay, there's a couple of methodology questions about the bubble study. Was this a standard bubble study? And then you reported counting hits for 20 seconds. At what time did your 20-second interval commence?
Sure. So at the end of the injection is when we started our 20 seconds. For the most part, initially for these 18 patients, we were trying to just draw back a little bit of blood. Almost all of them had an arterial line, so it was easy to get some blood to mix in with the saline. And we tried our best to inject into an upper arm IV, or a lot of them had central lines, and so we were injecting via central line as well. Now, obviously, an upper arm IV and a central line are actually going to change the amount of time before you start seeing bubbles, which I think is one reason that I don't think we can consistently look at the timing of the bubbles and decide whether it definitively is intrapulmonary or not, because I think there were just because of the nature of how we were doing it, it was not very consistent. Currently, we're doing it in a much more consistent way. So we're requiring that there be an IV in the antecubital or above. And we're doing it 3 times each, averaging it. What else, Hooman? What are we doing differently this time? Bacteriostatic saline. We're using just bacteriostatic saline, no blood, to kind of have a consistent contrast.
And what about the timing of your how many cardiac cycles are you basically using that? Are you using that to distinguish between cardiac versus non-cardiac source of bubbles?
We haven't been. I think you could, and I would probably use 5, but I don't think that we're necessarily consistently doing it enough. And the variability of the IV location and the IV size, I think just makes it that I wouldn't feel comfortable saying definitively one way or the other. I don't know. What do other people think? I'd be interested to hear what you think, Dr. Malkov.
Well, that you'd have to use something like after 5 to 7, but that's just an off-the-cuff answer. I'm sure there are other people in the audience that have been typing in questions that would have other opinions.
Mm-hmm.
Did any of these patients have a stroke that you know
of? So one of them had an identified stroke. Actually, he had presented with a left MCA and then had recanalized on his own. The other ones did not, that we know of. And anytime we lightened sedation, we did not see anything necessarily focal, but again, it doesn't necessarily mean anything. There was one patient who had a lot of bubbles, and we did a bedside echo and she had a PFO, so we excluded her. She had had strokes during her hospitalization that were identified when she woke up.
Okay. Regarding the patients themselves, when were they intubated in terms of how many days were they intubated, and what were the median number of days of COVID that they had, or what was, the range?
Yeah, so these were definitely patients who were, I would say, late stage severe COVID. So on average, I'd say probably about 12 days from time of onset of symptoms. And most of them had been intubated for several days before we scanned them for this particular study. And so certainly they were sick, but it was kind of late stage disease. In terms of their total survival, many patients died within days of having our scan done. So these were extremely, extremely sick patients, not like the patients that we're seeing right now.
This is another sort of methodology question. If you're going to get Lindegaard ratios, will you need to bring a tech into the room to do that?
I would probably just do it myself at the bedside.
So
yeah, I wouldn't. I think in general, our issue, we've talked about doing echoes on all these patients too, and I just have, I have a problem asking a tech to come in for a study that's not necessarily clinically indicated, just because the risk is so high. I take care of these patients all the time, and so does Hooman, and so I think we feel comfortable going in there to do it for our study. But I certainly wouldn't ask a tech, unless someone is volunteering and wants to be involved in the study. I wouldn't ask anyone to come in and do it themselves.
Okay. All right. There are a couple of other questions just generically. I assume that these people were sick and on basically unusual ventilator settings and drips. Is that correct? Most of them?
They were very sick. They weren't on necessarily unusual ventilator settings in that, most of them were on, significant amounts of oxygen and kind of normal, vent settings that we would use. The drips, yes. Often they were heavily sedated and often paralyzed. And that was more because of the agitation that would ensue, and that was difficult to manage otherwise.
All right, because okay, I guess the question is, did you notice anything? Did you try to do anything to reduce embolic burden and study that?
So I would say, so we didn't see any emboli at all. There was no spontaneous emboli seen in any of the patients. I described 10 patients where we did a full 30-minute study, but in all the other patients there, we never saw one spontaneous embolus. Most of these patients were on anticoagulation as part of our hospital protocol. And if they were not on anticoagulation, it was because they couldn't tolerate it because of a hemodynamically significant GI bleed or something.
Okay. All right, I think that at this point we've answered almost all the questions that can be answered on the chat. Do the audience have any other questions they want to type in? Here's a couple more. Yeah, and the other question, I guess, which I think you answered, but did you vary CO2 at all to evaluate activity?
These were not patients where we were able to vary CO2. These were patients who routinely had CO2s of 60 and above, and we just were not able to ventilate them better. I think, it's hard to convey like how sick these patients were. They were like, we would flip them over and they would code.
I think that is that, you know, transporting these kind of patients is just not for imaging, is just not easy.
It was not possible. I mean, we had patients who we would prone them and they would code and we would have to flip them right back over. Just small changes, even asking them to lie flat versus sit up for changing when nurses were changing them. Like a physician had to be in the room for cleaning because they were so unstable. So unfortunately, you know, there was no way to get a CAT scan on them. I think this newer study will be more helpful because these are patients who are not so sick.
The other aspect is they spontaneously would decompensate in front of our eyes as well. And it felt like we would turn around and all of a sudden they were on maximal vent settings and on high vasopressors. And then, you know, often we thought we would make interventions that make them better, or it felt like we had no control and things were just, you know, going on its own. And it speaks to the confusion of what this virus is actually doing.
Okay. Somebody's asking a question. Any comments about expiratory nitric oxide levels in COVID?
We haven't measured it. You know, that was something that we were kind of punting around initially about, could this be a dysregulated nitric oxide causing all of this vasodilation? Unfortunately, the issue that we're dealing with is nitric oxide within the blood vessels of the lungs. Most of the exhaled nitric oxide comes from the airways. So it doesn't necessarily help us from that standpoint. You know, we would need to figure out another way to determine nitric oxide issues within the vasculature. And these are intubated patients. You know, the exhaled nitric oxide is something we do in the office.
Mm-hmm. All right, are there any other questions from the audience? We're nearly at the end of our hour. We have a couple more minutes. If not, I would like to thank the presenters for their excellent work and their patience with my moderation, and compliment them on their ingenuity for describing a rather unique phenomena, which unfortunately is rather pertinent to our time. There are a couple of outstanding chat messages which I think can be answered offline. Is there anything else? Does anybody else have any other questions or anything for our presenters? If not, on behalf of the American Society of Neuroimaging and our sponsors, I would like to thank everyone for participating with this in this study. in this webinar. And I really want to thank the presenters for presenting their information.
Thank you for the invitation and for all the questions.
Yeah, thank you all. Great. Stay tuned.
Thank you.